Non-regenerative anemia is our next kind of anemia to talk about. And we've already talked about kind of this last one here, iron deficiency, and that's only in certain types of iron deficiency when you've sort of completely run out of iron and then you then decrease your erythroid production, and then it can become non-regenerative, but we know it can also be regenerative. And of course you're going to look at a decrease in MCV and a decrease in MCHC to support this. For every other type, these non-regenerative anemias are almost always going to be normocytic and normochromic. And of course, you'd expect the retic count to be non-regenerative, so a normal retic count, and that's by definition. So we're going to go through each of these with the exception of anemia of chronic disease, which I'll do separately. So in chronic renal failure, we have essentially a lack of EPO production. So normally the kidneys make EPO, and then of course this EPO goes to the bone marrow and we make red blood cells because of it. And so in this case you lack EPO because you lack functional renal cortical tissue. And this we usually say is greater than around 75% of renal tissue lost, but there's other mechanisms that can lead to the anemia. So how we identify renal failure, chronic renal failure causing anemia, is we look for azotemia. That's an increase in nitrogenous waste products, so that's BUN and creatinine. We've talked about BUN a little bit, not creatinine. And a lack of concentrating ability. So your kidneys can't concentrate, and so we see that as a decreased urine-specific gravity. And the real one that we look at is isostenuria, which means that the concentration of your urine is no more than the concentration of your plasma. It's the same ISO, but we look for urine-specific gravity that's less than 1035 in cats, less than 1030 in dogs, and less than 1025 in large animals. And then again, isostenuria means that the kidneys can't dilute the urine and they can't concentrate the urine. So just quickly to remind you how the kidneys work is here's our glomerulus and blood comes in, and the glomerular filtration means how much blood is kind of getting through your glomerulus, because that's the filter. And that can be decreased due to decreases in blood flow getting to your kidney because of such things as dehydration, but then you'd expect your urine-specific gravity to be increased, so you'd expect it to be greater than all of these numbers. So the other cause is where you actually have decreases in numbers of functioning nephrons, and that's chronic renal failure. So you will have less, this whole unit, glomerulus plus tubule, is actually a functioning nephron. And so you normally have many of those in your kidneys, your patients do. And so if you have less of those, that leads to renal failure and decreases in glomerular filtration. So you'll see azotemia. Since you have decreases in nephrons, meaning your tubules where you concentrate your urine, you will then see that lack of concentrating ability. So if you see that coupled with the anemia, and especially if it's non-regenerative, it supports a decrease in EPO leading to the anemia. And we'll go into much more detail when we actually talk about kidneys. So while chronic renal failure leads to a lack of red cell production by the bone marrow, it's not a bone marrow disease per se, because it's a lack of erythropoietin. You can also have bone marrow disease that causes anemia, and this can be due to generalized causes. And of course, we know that along with red blood cells, white cells, especially neutrophils, and platelets are all made by the marrow. And the lifespan of each of these, so red cells last a long time, remember 3 to 4 months. White neutrophils specifically last around 12 hours in the blood, and platelets last around 5 to 7 days. So you can imagine that if there's bone marrow generalized disease, it's going to impact neutrophils first, then platelets, and then last it'll affect red blood cells in terms of decreases in production. So things that cause generalized marrow disease are going to be things like infiltrating neoplasia, so maybe it's lymphoma, it could be some sort of fibrosis, it could be things like infections. Certain infections can cause generalized marrow disease. lots of things can cause generalized marrow disease. I would say the most common probably is going to be infiltrating neoplasia, but how you recognize it, at least for our purposes, is you're going to look for other cell lines decreasing. And so you expect to see what's called a pancytopenia, where all three lineages are decreased. Contrast that to red cell specific, you only expect to see anemia. And in both of these, the anemia can be very mild or it can be very severe depending on when you see it. But it's a chronic anemia, usually, at least for red cell specific. Pancytopenia, it may depend on when you catch it. And so in this case, the marrow stops making red blood cells altogether, and that's called erythroid hypoplasia. And this can be immune-mediated, idiopathic. We don't always know what happens. And then you can actually have targeting of erythroid regeneration. So you can target the erythroid progenitors. So you're going to target these red cell progenitors, and you can target them early or late. And so then your red cell production may be different. But the end of the line is that you're anemic, and the only way to diagnose this definitively is to evaluate the bone marrow and look for what's actually happening. So you can't diagnose this just on a blood smear, but you can suspect it.